Hi, everyone, and welcome to Advances in Breast Cancer Treatments. My name is Janine Guillermino, and I am the Vice President of Mission Delivery at Living Beyond Breast Cancer, and I'm pleased to be here today with Dr. Claudine Isaacs. Dr. Isaacs is a professor of medicine and oncology and associate director of clinical research at the Lombardi Comprehensive Cancer Center at Georgetown University in Washington, D.C. She is medical director of the Jess and Mildred Fisher Center for Hereditary Cancer and Clinical Genomics Research. And if you'd like to read more about Dr. Isaacs, please go to lbbc.org to see her full bio. Thanks, Dr. Isaacs, for joining us today.
Thank you for having me.
So today we're going to be speaking with Dr. Isaacs about how breast cancer has evolved over the last decade. And we're going to talk about some key factors that determine treatment options for people with early stage and metastatic breast cancer, as well as the use of clinical trials and treatment. So we're really excited to have this discussion. So let's go ahead and jump right in. So Dr. Isaacs, a lot has changed in the recent past in the treatment of breast cancer, but let's just look at the last decade. What would you say are, in your view, the ways that breast cancer treatments have improved in the past 10 years?
You know, there's so many ways. It's a hard question to start with. The great news is that survival continues to improve. So for women with early stage breast cancer, we've made advances in all areas of breast cancer. So in HER2 positive, hormone receptor positive, and triple negative. This has resulted in an increased chance of being cured of early stage breast cancer. And then the metastatic setting, we have just seen an enormous explosion in different numbers of drugs and types of treatments that have again changed the landscape of what we do. So the great news is that for women who are diagnosed with early stage disease, we have better tools to identify who needs which treatments and to avoid some of the toxicities in people who don't need them, and to overall improve outcome. And then in metastatic disease, because we have new treatments, and some of these are new targeted treatments, some of them are immunotherapies, some of them are new therapies for hormone receptor positive, we are prolonging the lifespan of women with metastatic breast cancer.
Thanks very much, Dr. Isaacs. It's exciting to hear that the developments have been both in the treatments themselves, in the management of side effects, and even in the testing that helps us to select the right treatment. So that actually leads to our next question, which is, when you are talking to a newly diagnosed person, what are the key factors that you're thinking about in selecting their initial treatment options?
I think of the treatment factors really are being broken out into different groups. So what are what's related to the cancer? What are the characteristics of the cancer that help drive us to make recommendations for the best treatment? And by best treatment, what I mean is not only everything, but what can we pull back on? And when do we need to initiate certain treatments or not? And we can get to some examples because I think it'll make it a little bit more granular as we discuss that. But we're talking about the treatment, the tumor-related factors. Then we need to think about the patient herself. What are the other illnesses or medical conditions that she has? Does she have any particular issues that might push you more to one treatment or the other? And then the final thing in breast cancer, as people who have walked down this path probably know, there's often not a single right answer. And there's some choice and preference that's going to come into it. So then I think of that as being, related to the individual person's preference. How do they weigh a relative benefit of X percent? Is that worth it to them as a trade-off for the side effects of toxicity? So I really think of it in those three ways. And maybe we can get, maybe we can talk about some examples to make it a little bit more understandable, a little bit more concrete. So let's take the example of hormone receptor positive HER2 negative breast cancer. So I think many people who are listening to this know that we divide breast cancer into a number of different categories. So we think in the broadest possible categories, we think about HER2 positive breast cancer as being one thing, hormone receptor positive and HER2 negative as being something else, and triple negative as being sort of the third area. So let's just take one of them, for example. We'll take the hormone receptor positive. We have a very, very large trial that was just presented. This is a trial that many institutions across the nation, including ours, participated in, that really was trying to delineate the role of chemotherapy for women who had hormone receptor positive, HER2 negative breast cancer. And you turn the clock back, you know, a decade, or maybe not quite a decade, but 2 decades ago, more than that, we were recommending chemotherapy to virtually everyone who had even hormone receptor positive, node negative breast cancer. And we recognized that we benefited a very small amount, but we were subjecting tons of people to the side effects of chemotherapy who probably didn't need it. And so we now have a test that is very standardly and routinely done on tumors for women who have hormone receptor positive, HER2 negative disease, a test known as the Oncotype DX test, that we now have really solid data that allows us to tell us, beyond what the pathologist says on the initial report, allows us to say, well, based on these tumor characteristics, there is no benefit of chemotherapy over and above just standard hormone therapy or endocrine therapy. But for that particular tumor, there is a significant benefit of chemotherapy, and we should do it. So it allows us to really be much more tailored or individualized in our treatment recommendations. The other area that I just want to, talk to people about is that for the other subtypes of breast cancer, for triple negative and HER2 positive, we actually have clinical trials that now further solidify the role of doing preoperative chemotherapy or preoperative therapy for those women, for the vast majority, not everyone, okay? So none of this is everyone, but not only that is a place where we can have clinical trials that are looking at novel treatments or pulling back on treatments, but also because we know that it's critically important for us to tell how the tumor responds to the therapy that we give. And if somebody goes to surgery first, tumors in the pathology departments, right? I mean, that's great. We love it to be in the pathology department, but we lose the ability to assess or to ascertain what the response, how that tumor is shrinking in response to the treatment that we're giving. And that's really complete individualization, right? It's not doing some test tube experiment to say, oh, will this tumor respond to this treatment? It's actually giving a person a particular treatment and seeing whether the tumor shrinks and goes away with it. And up until a few years ago, all that we knew is, okay, it was fantastic. It was really good news that the tumor disappeared completely. But we didn't have anything that we knew that we could do that would change outcome for the group of women where the tumor hadn't completely responded to the treatment. And now we have good clinical trials showing us that for women whose tumor does not completely disappear in response to the preoperative therapy, that if we change the therapy out back following surgery, we can improve outcome. And we and others we have certain things that have now become standard of care in the last year. And as usual in breast cancer, we're not resting on our laurels. We say we want to do better than that. So we're about to open up a clinical trial that's trying to see if we can do even more than that in women who have HER2 positive breast cancer, for instance, who get preoperative therapy and still have some residual disease. And then we also, lots of people have trials looking at for women who are triple negative, can we do better than what is the current standard of care? And the current standard of care in these things is like, 2 to 4 years old. So it's not really old, but we're consistently and constantly as a group trying to keep on doing better.
Thank you very much for addressing that and for talking about neoadjuvant therapy. And I want to follow up with a question. I think for people who are newly diagnosed with breast cancer, this idea that we might not be throwing the kitchen sink and doing every treatment can sometimes be hard to understand or absorb because it is sort of a newer approach to treating breast cancer. Can you speak to the kinds of questions someone should be asking a physician about, am I getting enough therapy? Am I getting appropriate therapy? What are some of the types of questions someone might want to ask their physician to feel assured that they're getting appropriate treatment?
I think that's a great question, a really important question. I think particularly, if you're at a academic center, I think people tend to think about all of these things more broadly in general, but not always. I think a great question is, what are other options? Are there other options? Are there other things I should be thinking of? Is a really good question. And you know, many people will see a surgeon first. And the paradigm has really shifted a little bit because we're talking about neoadjuvant therapy, and we're talking about neoadjuvant therapy even for women who have relatively small tumors, because it's, in many instances, it's so important for us to be able to assess whether the tumor has responded or not, that we're initiating. We used to only give neoadjuvant therapy for women who had larger tumors or who had a lot of nodal involvement at the get-go, but that has really shifted in just the last few years. So I would certainly make sure that, you know, going to somebody with a new breast cancer diagnosis, it's obviously a really scary moment. And most people's instinctive reaction is like, get it out of me, okay? And if you could take me to surgery tomorrow, I'd be delighted. But I would take a breath, and I would make sure, I would pause, and I would say to the surgeon, should I be considering neoadjuvant therapy before? Because sometimes they actually schedule you for surgery like in 5 days, and that feels terrific, but you might actually be losing the opportunity to assess how your tumor responds to therapy. In some cases, it's absolutely appropriate, but I would make sure that when somebody is seeing the surgeon, that they say, you know, I've heard a lot about neoadjuvant therapy, neoadjuvant chemotherapy, or neoadjuvant other therapy. Should I be considering it? Should I be meeting with the medical oncologist first to have that discussion? Because you really don't want to lose that opportunity. And then when you're with the medical oncologist and they're talking about your options, say, you know, are there any other treatments I should be considering? How do I weigh these different options? So to inform yourself on that. And then I guess one more point is, you know, COVID has made this harder, okay? But bring somebody with you, okay? Technology at least we've all gotten better at technology too. So if they can't actually physically be with you, and for a certain period of time, many institutions, ours included, you know, had narrowed it down, and we were initially where you can bring one person, then don't bring anyone, and now we're back to you can bring somebody, and it's going to ebb and flow. But if you can't bring somebody to be with you in the room, make sure they're with you. Bring them on your cell phone, bring them on whatever, have another set of ears, have somebody taking notes, record so you can absorb it, because it's really, really complicated what we're talking about often. And to be able to integrate all of that and figure out the next step forward can be really confusing.
Thank you. That's really helpful. And certainly we're hearing that a lot of people are bringing their cell phones into appointments with them and are able to have their loved ones with them, even if they can't be physically with them. So we've talked a lot about the early stage setting. Are there any factors that are different in the metastatic setting when you are selecting an initial treatment?
So again, that's a great question. It's going to be very, very subtype dependent when we're thinking about that. There have been a number of developments in virtually all aspects of breast cancer. You know, the first line setting, maybe for HER2 positive, hasn't evolved that much yet or recently. I mean, there was a paradigm shift, you know, about 8 years ago or so. And so the standard first line therapy for most women is going to be chemotherapy plus 2 antibodies, trastuzumab and pertuzumab, that are also known as Herceptin and Perjeta. And there are a few there are a few things that are new in that area, but that's the basic backbone of what we're doing. In triple negative breast cancer now, we have evidence from a number of trials that for some women with triple negative breast cancer, immunotherapy with chemotherapy is the way to go. And that's given in conjunction with chemotherapy. And that's going to depend on whether the tumor expresses a certain marker or not. And that's something that routinely pathology departments do. So increasingly, you know, the medical oncologist is going to be speaking with their pathologist and saying, could you check whether the tumor has X or Y on it? Sometimes that can just be done in the pathology department's a routine test. Sometimes there needs to be a deeper dive into things depending on the type of cancer. So sometimes we send it off for what's called molecular profiling, which is sent off typically to a company. It can be done either on the biopsy itself. We, in some cases, can also do it on blood test. It's called a liquid biopsy. That is not always as sensitive, meaning that sometimes it could be negative on the blood, but it could still be positive on the tumor. And so we're using those factors because we have a number of targeted treatments that are around. So in the first line setting, just to get back to your question, in HER2 positive, there's a pretty set standard these days, although there are a lot of studies trying to see whether we can dial back on that, whether we can do something more on the after the initial chemotherapy and antibody phase is done, whether we should be doing something different there. In triple negative, the routine thing to do these days is to check whether that person's tumor, whether there's a benefit or potential benefit from the addition of immunotherapy. And in hormone receptor positive, our paradigm again shifted probably around 5 years ago or so for the addition of this class of drugs that are called CDK4/6 inhibitors that are given in conjunction with endocrine therapy. On subsequent lines, we're often doing more in-depth testing to help guide us. There's some new targeted therapies that have come out. There are clinical trials that are looking at other targeted therapies. So there's lots that's going on. So often repeat biopsies are done or repeat testing is done to see whether some of these new drugs might be effective.
Thank you. That's really helpful. And we've talked a lot about new drugs. We've talked about new approaches. All of that is possible because of people participating in clinical trials. Can you please speak to the role of clinical trials when you are offering treatment to the people that you see in your facility?
So, that's, again, it's another critically important question. What we do today as standard of care is because of the thousands and thousands of women who participated in yesterday's trial. And we keep on making advances because of clinical trials. That's the only way that we're doing something better today than we did yesterday. And the other thing that we're trying to do is do something better tomorrow than we're doing today. So I deeply, deeply believe in clinical trials. When I'm sitting across from somebody, that person doesn't have to participate. Individuals, it's our job, it's our role as a clinician to treat and offer the best treatment to the person that is in front of us. And that best treatment, we talked about preference. There are some people who feel comfortable with trials and some people who don't. And we obviously strongly respect whatever preference somebody comes with. I always tend to talk about, this is the standard of care that I would offer you. So these are our options in standard of care. And then say, and we have a clinical trial that you might be interested in, and discuss it. But the decision is very much on an individual basis. But clinical trials have really continued to revolutionize what we do. So I can't stress enough the importance of clinical trials, and they can come in lots of flavors, okay? So there are clinical trials that are looking at novel therapies, that are, really trying to look at some drugs that are first in human and could they make sense? And a lot of it is based for a drug to make it to clinical trial. There has to be strong scientific evidence for it. That being said, many trials that make it to the initial clinical trials, don't see the light of day. And even the ones that make it to phase 3 might not be better than yesterday's standard. But a chunk of them are, and that's how we keep on improving. So we have clinical trials in all aspects, and they come in different, are they first in human? There's a real signal of efficacy, and we're going to do another trial where we're really going to try and hone down on that. And then we're going to do a definitive trial to try and really, really prove that this is better than standard of care. And I think we've heard it all with COVID. I think we're all a little bit more educated about clinical trials because of everything that's out there about COVID. And, but the other things, we have trials that are looking at symptom control. We have trials that are looking at exercise and dietary interventions in women who are survivors of early stage breast cancer to see whether there are lifestyle factors that can impact outcome. We have trials that are looking at easy drugs that, what we think of as repurposing old drugs. There's a big national trial, for instance, going on right now looking at aspirin in women with early stage breast cancer, because there's some fairly good evidence that it might do something. That would obviously be a drug that would be available around the globe where often they don't have the same access as in this country or in other countries, that and that could make a difference on top of things. So things can really come, trials can come and vary in lots of different types, and a lot of them are trying to just further improve things. So obviously I'm a deep believer in clinical trials. I live and work at an academic, institution. I'm at a comprehensive cancer center that's really trying to really help us push the envelope and figure out what next is the best thing. But we have great standard of care, and it's really important to know what the standard of care option and what the clinical trial is as well.
For someone who might be interested in a clinical trial, but who isn't at a comprehensive cancer center or who may not have had this discussion with their doctor, how do they ask about clinical trials? Everyone's doctor, who's out there, it doesn't matter where you are, they know the importance of clinical trials. They're staying up on it. The reason that they're recommending something as standard of care today is based on the clinical trial that was published that showed that that was the new standard of care. So it's a pretty straightforward question. I mean, the question is really, are there any clinical trials that you have available for me? Or are there any clinical trials that I should think of? And certainly for somebody with metastatic disease, I would ask. I would ask every time. I would ask whether there's something new. And just to remember, again, the instinct for most people, which is completely understandable, is, if you have if somebody has metastatic disease and they're told that the treatment they're on is no longer working, and they come in, to see their doctor with that scan result, and they say, well, I'm going to start you on this today. If they start you on that today, whatever that is, you're not eligible for a clinical trial in that setting because you've just started on a new therapy. So even though the instinct is, let me do something immediately, it is important to ask, what are my options? Do I have any clinical trials I should be thinking of? And maybe it's not at your doctor's office, but maybe, at the academic center that's not too far away, they have clinical trials. And most academic centers have their clinical trials available online. Clinicaltrials.gov has it as well. It's a little hard to navigate that site, but they restrict it. They do geographically. They tell you where you can find things, the stage of cancer. So there are resources available, and you might be able to speak to it. I think, many organizations have resources to help people navigate that question. But I would just, if possible, not jump at that second to the next treatment, but really ask the question, is this the next best step? Just like we talked about in early stage disease, if you schedule your surgery on Monday, you've taken away your ability to participate and to get neoadjuvant therapy and get that assessment if it's appropriate. It's not appropriate for everyone, but if you don't ask that question, it might not happen. Absolutely. And we do have a variety of resources to connect to clinical trials, both in the early stage and the metastatic setting. We have a link to metastatic trial search at lbbc.org, as do many of our colleague organizations, for those of you living with metastatic breast cancer. So let's talk a little bit about some specific trials. I know there's hundreds of trials to choose from, but when you're thinking about, say, the early stage setting, is there one or two particular trials that really excite you and that you think could make an impact on treatment in the future?
So obviously I'll talk about it from my vantage point, and there are lots of them.
Sure.
We're participating, and we and 25 other institutions across the country that have a lot of expertise in breast cancer are participating in a trial known as the I-SPY 2 trial, which is a neoadjuvant trial. That is a trial that is really trying to evaluate the efficacy of some novel drugs typically on top of standard treatment, although increasingly trying to figure out if we can pull back and by pulling back on some of those standard treatments, potentially minimize toxicity. So it is the trial that really gave the initial signal for the role of immunotherapy in neoadjuvant treatment for triple negative breast cancer. We all think that it is quite likely that will be FDA approved in the next year or so. And this trial offered women the opportunity to participate in it, to get neoadjuvant therapy, to have a really close follow-up of the tumor. In that trial, people get more intensive imaging so we can really tell how the tumor is responding to the treatment. So if you're on a different therapy and we don't like how it's going, we can change course. And so it's a trial that many of us are really excited about, and it's open for all subtypes of breast cancer. Has to be high enough risk. You know, we don't want to expose people who have tiny tumors that have a great prognosis to novel therapies, but it is a trial that we're really excited to participate in, and that many institutions across the country, so it's available in places across the whole country as a potential clinical trial. There are trials that are trying to sort out issues related to HER2 targeted therapy as well. Could we minimize some of the chemotherapy backbone of it? So the large cooperative groups, and that's typically available more widely across the nation, are in the process of opening up some clinical trials that are trying to take that concept. If we give neoadjuvant therapy and people have complete disappearance of tumor, we think that's the ultimate place that we want to go. What it takes to get from, you know, tumor getting chemotherapy, what drugs there are in there might not matter. So maybe if we just get to that complete disappearance, we're there. So if we can do it with fewer drugs and with less side effects, that would be great. So there's trials trying to look at whether we can dial down on that as well. So the community is really, the medical research community and the medical community in general is really focused on attempting to right size our treatments, you know, to do what we can. Lots of places are looking at other things. We're working on a trial that's not yet open, but it's in development, trying to look at whether we can address some of the toxicities of treatment. So we have a trial that, you know, I don't know, these trials take a long time. They have a long gestation period, but we have a trial that we're working on in collaboration with our basic scientists and with other members of our cancer center, that's going to try and look at whether we can give a drug to reduce the cognitive impact of chemotherapy. So to try and address that concept of chemo brain. So there are lots of trials in so many different areas that are really, really exciting. That, you know, it really is incredibly hard to answer that question. But it just goes to, I think, I'm hoping, it seems like the country and in general, people are understanding what clinical trials bring to us, and what clinical trials bring to us are not only improved treatments, but also dialing back on the toxicities of our prior treatments, as well as a slew of trials that are trying to mitigate some of the side effects of treatments.
So really selecting the most appropriate treatments for each individual situation is kind of the direction where we're moving.
It really is. It's this individualization, this personalization of treatment.
So Dr. Isaacs, you had mentioned a little earlier in our discussion about the impact of COVID-19, and certainly the pandemics had an impact on the clinical trial enterprise. How do you see people's ability to participate in clinical trials being impacted by the pandemic? And do you think those changes are permanent or will turn around as we begin to recover in this country?
So, you know, COVID-19 is something that we are all navigating together, and it's an ever-changing place. It's a little bit, it hasn't normalized, but I think we have a little bit better sense of how we need to live with it and what we need to do about it. There was initial, obviously, tremendous worry about it, and worry about the impact of our treatments and how that would change risk for people. Would it increase their risk of getting COVID, excuse me, or would it potentially worsen symptoms? And the good news in breast cancer is that for most people, particularly for early stage disease, it doesn't look like getting treatment for early stage breast cancer significantly increases the risk of developing more severe COVID. Not to say that there is zero increased risk, but you know, we were really petrified at the beginning, and we were changing everything that we did. But obviously we're telling people to be physically more distance. We're discouraging people from going out much. You know, hospitals and clinics have become much safer. And certainly they really took it to heart, and they understand infection control and safety. So I actually think that they're very safe places, and people are practicing what they should be practicing in order to be safe from COVID. But clinical trials do require people typically to come in more often, and that's a hindrance. If you're telling somebody that they should stay at home as much as possible, and yet the clinical trial wants you to come, every week, and you wouldn't have to, or something like that, that's something to take into account. That being said, clinical trials have evolved as well and recognize that. So they are transitioning a bit. They're letting people stay closer to home, to have their labs done closer to home in some cases. Telemedicine is replacing some of the in-person visits. So there are ways that clinical trials have evolved. What we did initially as a medical oncology community was trying to grapple with, well, how do we deal with this short-term horrible thing that's happening, this pandemic that's happening, but still keep our eye on the fact that for women with early stage disease, and also for women with metastatic disease, we have that long-term picture, right? We don't want to pull back on treatment so that we're increasing their chance of succumbing to the cancer because we're not doing the best treatment that we can. So I would urge people, if you have something, a real illness or a real medical condition that needs to be addressed, it needs to be addressed. We need to keep that in mind, and the medical community has figured out how to deliver care safely, how to pull back on things that we were doing just because it was easy to do something. Well, maybe we don't do it like that anymore, so we have changed in response. The other area I think to really touch on that we haven't really gotten to is this whole area of cancer screening. We're seeing way few cases of cancer in general, which is really worrisome because it's not going away. It's not that COVID reduced the likelihood that somebody would develop cancer, but people are postponing their screening. They're postponing their mammograms. They're postponing their colonoscopies. They're postponing their visits to their primary care doctor. They're doing all of these things. We know that in general, the cure rate for cancer is greater the earlier it's detected. So we really, really urge you, if you, your friends, your sisters, your mothers are not going for their routine cancer screening, they should. That medical and imaging and various places have figured out how to do social distancing, how to make sure everything is super clean, how to wear masks, how to do all of those things to make it safe for people to have their cancer screening, because we don't want to be seeing a bunch of cases of advanced disease because we stopped the clock on screening.
Thank you for speaking to that and really speaking to the way the pandemic has affected every part of life and approach to cancer. It's the clinical trials, it's the treatment, it's the screening. So a lot of things have changed in the past 6 months. And as you're thinking about the future, say down the road, we sort of started this conversation talking about how things looked 10 years ago. If you look 10 years ahead, knowing everything we know about what's happening right now, and just about how everything has changed over the past decade, what do you see as the future looking like for breast cancer treatment?
I think, again, we're going to get much more personalized in what we do. For instance, if I take us back to the I-SPY 2 trial, the one that I talked about before, when in those trials, there is collection of blood and tissue, because even if a treatment works in a certain subset of breast cancer, it's not going to work in everyone, or it might work particularly well in this group and then not in that group. And so we're all interrogating things. We're all really using these clinical trials to maximize the amount of information that we get, because what we want to do at a certain point is, we want to get what we do now, which is get a biopsy and see what's going on, but probably do a lot more testing to help us ascertain which treatment is the best. We're going to be much more specific and much more individualized in our treatment. And I think we're going to be pulling back on a lot of the chemotherapies that we were routinely using. We'd be saying, I think we're going to have a lot more targeted treatments, and we're going to hopefully be able to diminish the toxicity of the treatments that we're giving by really focusing in some ways sort of in the right drug and the right person at the right time is sort of a mantra that I think we're trying. We think that we're getting closer to, but we're not there yet. And I think we'll be much closer to that in a decade. I also think one of the areas that we want to be is we don't want people diagnosed with cancer, right? So cancer screening and prevention is going to be a really important place. And we know if we're thinking about things, what we can do in terms of lifestyle interventions will make a big difference. So, certainly, your primary care doctor talking about, getting diabetes under control, eating healthily, exercising, all of those things are so important when we're thinking about diseases in general.
Thank you, Dr. Isaacs. And before we wrap up, do you have any closing thoughts that you'd like to share with folks who are watching today?
I think the main thing is that things are getting better and better. And I think that there is continued reason to believe that we will be doing something different and better tomorrow than we're doing today. And medical advances are coming at a bit of a dizzying pace for all of us, which is terrific. That's exactly what we want. But when somebody asked me, I used to turn the clock back 20 years when I first started. I used to be very dogmatic. We're going to give you this treatment. This is the recipe, and you'll get this for X period of time. And now I say, look, our current standard is that you're going to get, let's say, for instance, hormone therapy for at least 5 years. But let's see where we are. And we're continually reevaluating based on the latest evidence. So for those of you who, had breast cancer a while ago, ask your doctor, is there anything new? I mean, that's the other question in some ways. We talked about what do you ask when you first meet with your doctor. But the question for people who are coming in follow-up is to say, is there anything new? Is there anything I should be thinking of? For somebody who had genetic testing in 2008, you know what? It's not the same genetic testing in 2020. Should you have new testing done based on the advances that we've made? Just every time you're going for that annual checkup, say, is there anything new I should be thinking about? Have things changed that impact me? And that's one of the reasons why, I have people come regularly. Many of us have long-term survivorship clinics where we have these touch points because things keep on changing. We always have to sit back and say, okay, that's what I did then, but I think we should be doing this now. So I think that the main thing is a message of hope, that survival is getting better and better. And that's true both for early stage disease and for metastatic disease. And I think it's just going to keep on improving.
Thank you very much for that, Dr. Isaacs. And thank you so much for sharing your time and expertise with our community today.
Thank you very much.
And thanks to all of you for joining us today. I hope that you got use from this program. We are asking you when you're done to fill out an evaluation and let us know how we did and how we can be helpful. And I hope that you'll continue to follow us at lbbc.org for ongoing information about breast cancer treatment, the pandemic, and ways that you can improve your quality of life. Thank you so much. Take care, stay healthy, and we hope to see you again soon.